So Adnan, I hope you're in the meeting. You can start. I think we were here, so we are continuing from yesterday.
Question 38. All right. A patient from a malaria endemic area presents with a markedly enlarged spleen. So the following statement is true. The condition is most likely to secondary to a lymphoproliferative disorder. The cause of a large spleen is portal hypertension. The condition is due to a chronic antigenic stimulation derived from the malaria parasite. This is a finding that is more frequent in non-endemic malarial zones, and E. pancytopenia present is associated with a hypoplastic marrow. So you know that in case of chronic malaria, what happens is a condition known as hyperreactive malaria splenomegaly, or sometimes referred to as tropical splenomegaly syndrome, due to the continuous malarial infection. You see, they explain like people in the lake region, in Kisumu and those areas, they are repeatedly attacked by malaria, by the mosquito, the mosquito bites, and they have repeated bouts of exposure to the malarial antigen. And due to that one, they develop this chronic malaria known as the hyperreactive malaria splenomegaly. And hence, the most correct answer is going to be the condition is due to a chronic antigen stimulation derived from the malarial parasite. Right. I think question 40, we had already done it, about the delayed concept about delayed hemolytic transfusion reactions, and how you're going to have that. The concept was to be able to have um, the reaction taking place within a period of time and not immediately. So the rest of the questions have almost immediate answers. But then we talked about and said that delayed type takes between 2 to 10 days. And hence, you're going to have the development of symptoms associated with a hemolytic anemia are taking place after some days. And we gave the answers a fall in hemoglobin days after transfusion with the mild jaundice. All right. This is also a question I talked about it indirectly, but not the same question. Which of the following red cell abnormalities is most indicative of hemolysis? So among the choices, which is the most indicative that there is a hemolytic anemia are taking place? So you should know, for example, acanthocytes, at what conditions acanthocytes are seen, things like a liver disease or a beta lipoproteinemia, alcoholic liver diseases and something like that. Basophilic stippling, the heavy metal poisoning such as lead poisoning. You can think about thalassemia is also taking place. Target cells, you'll for the case of target cells, and you'll want to talk about the hemoglobin C disease or thalassemias or even liver diseases. For Heinz bodies, you want to talk about G6PD deficiency. So yesterday I talked about and referred to a question where we were talking about the MAHA, yeah, the microangiopathic hemolytic anemia. And we say that what happens there is that there'll be mechanical hemolysis taking place, yeah. And we talked about and referred, and we said that there'll be formation of these fragments. I mentioned something like helmet cells or different other shapes of cells, which are then referred to as schistocytes. So the most correct answer here, when you're talking about hemolysis, will be schistocytes.
Sorry to take you back. There's someone who has a question on question number 38. He wants you shed light on option A, why I think option A was not an answer.
The condition is most likely secondary to lymphoproliferative disorder. All right. So, we're just looking at the most obvious answer, the most correct answer, yeah? So you already talked about, we said that it's an malarial endemic area. And we gave an example of the places like Kisumu, yeah? Where you'll have like the person is going to be exposed to the malarial antigen in several bouts, yeah? So several exposure, yeah? So you're looking at, okay, a lymphoproliferative or even some of these lymphomas can be able to present with a splenomegaly. And you talk about splenomegaly or hepatosplenomegaly can present in so many other conditions, but we're looking at the most correct here in case of what they have given us, in case of malaria endemic area. Yeah, for example, Burkitt lymphoma, even the Hodgkin's lymphoma can present as a splenomegaly or hepatosplenomegaly. So we are looking at the most obvious, meaning. Right. So factors that will modify causation of anemia by the parasites and severity include all except the parasite pathogenicity. That's correct. I will talk about the socioeconomic status of a population, the general health status of a population, and the dietary hematinic content. For this one, I just went ahead to take it from the notes. The notes clearly puts all the other answers, excluding choice A. So it's directly in the notes, because all the rest are put there except the parasite site of entry. Right. So the diagnosis of immune thrombocytopenia, ITP, does not initially. You see, the word is most importantly is the word initially. Yeah. So the diagnosis does not include initially. So it's you would want to do your platelet antibodies from your serum, yeah, and you'll see a question associated with what antibodies are associated in the ITP cases and what they'll do, yeah. So you'll also want to do your total blood count, to be able to see what's happening with your platelet numbers, yeah. Your bone marrow examination, platelets are being produced, or what's the platelets within your bone marrow, the megakaryocytes and blood film. Yeah. So initial diagnosis will not include splenic specimen.
Is this hematology? Yeah, it's hematology.
So the question says, a 23-year-old is known to have HIV. He requires long-term follow-up due to the likelihood of developing malignancies. However, which one of the following that is not? However, not the following. Yeah. So we have some malignancies that are known as HIV defining, and some are known as HIV non-defining malignancies. Yeah. So if HIV defining, I think we all know Kaposi sarcoma and primary CNS lymphoma as good examples of them. We'll also have primary cavity and primary fusional lymphoma. So if you just go ahead and look at HIV non-defining HIV non-defining malignancies, one of the examples always given is going to be hepatoma. So hepatoma is not associated, defined by HIV. Okay, a patient requires elective orthopedic surgery and needs to have a standby blood secured. If in case, okay, HIV defining and HIV non-defining, I can see that, I can guess that HIV defining malignancies are those malignancies that are mostly associated with HIV patients. Yeah. So if you see the characteristic Kaposi sarcoma, one of the things you might want to do is check out if the patient has HIV. So having HIV is associated with these malignancies. It's more or less like having HIV and the common diseases that are associated with it, like tuberculosis, and such kind of diseases. So that's I think the explanation. So for this case, the clinician may suggest which of the following to the client to lessen the risk of possible transfusion reaction. Yeah. So this patient is currently not suffering. They are planning for a surgery. Yeah. And what's better than to have your own blood? Yeah. So some of the people and having an autologous, as you know, the different types of blood donations, you can have an homologous blood donation transfusion or an autologous one. So for autologous blood donation, it's the person you're taking your own blood, yeah, and then you know that I might need this blood. So before you are exposed to any condition that needs blood, you are able to have your blood you know to take your own blood, and then in case you'll need it during the surgery, then your blood is going to be used for transfusion, and that will be the most safe one because it's your own blood. Yeah. All right. What's the main enzyme in fibrinolysis system is? The main enzyme in the fibrinolysis system is, so I'll ask a question. What type of system is the fibrinolytic system? We classified them and we repeated it. We said we have primary, secondary. So where would fibrinolytic system fall? Anyone? tertiary. Yeah. So we saw another question asking about it. So it's tertiary. So the main enzyme in the fibrinolytic system is going to be the plasmin. Yeah. All of the almost everything around fibrinolytic system, they're going to try to activate plasminogen into plasmin for plasmin to then act to be able to degrade the fibrin. Yeah. So this is how it is. We have fibrinogen in its inactive state. Will require plasminogen. We have plasminogen in its inactive state. Will require something to be able to activate plasminogen into plasmin. Those things are known as plasminogen activators. For the plasminogen activators, we have two types. We have the tissue type, which is, as the name suggests, found in tissue and also blood. And then we also have the urokinase. So there are two types of plasminogen activators. The tissue type plasminogen activator given as trace B here, and we also have the urokinase plasminogen activator. And we can be able to have some how do I call it, pharmacological types as well, like the streptokinase, which are then prepared. But these ones are the things that we have them within our body. So plasmin will be the main enzyme. That's our main target. We need to have a plasmin for it to be able to degrade fibrin and to the fibrin degradatory products. Right. So in DIC, the following is not prolonged or increased. Yeah. So which one of the following is not prolonged or increased? So what's happening in DIC? In DIC, you're having there's an imbalance with the hemolytic system. There's you're using there's clot formations at the same time. You're using too much of your coagulation factors, in the sense that you're not going to have them to be able to prevent any bleeding. So in DIC, you're going to have two contradictory things happening. You're having thrombosis within your body, and you're not able to form clots, or you're not able to stop bleeding. So you're having bleeding and you're having thrombosis. How does it come? When you have thrombosis, you're using your coagulation factors. And when you use your coagulation factors, and you're able to have, you know, to not have enough of the coagulation factors, then you're not able to prevent bleeding. Yeah. So you're going to be able to use your coagulation factors. So which of the following is not going to be increased or is not going to be prolonged? Yeah. So if you're using your coagulation factors, you think about all the tests associated with the coagulation factors is going to be prolonged because you're not going to have them. Yeah. So your PT, your APTT, your TCT are all going to be prolonged. Fibrinogen, remember, is one of the coagulation factor. Coagulation factor, so factor one. Yeah. So you're using, we've said we are using too much of this thing, and hence you're not going to have them increased. Rather, in this case of DIC, fibrinogen levels are going to be decreased. Fibrin degradatory products are what happens. So when you use fibrinogen, you form fibrin, and you want to start to be able to break down fibrin by plasmin. And in DIC, one of the important tests that you want to do is this fibrin degradatory product, or the so-called D dimers. Yeah, is a good test to be able to check out your DIC. Yeah, so fibrin degradatory products are going to be high because you're forming too much fibrin, and fibrin is still being broken down by plasmin, and the whole system is haywire. So the only thing you're not going to have is fibrinogen levels increasing, is going to be decreasing rather, and all the other coagulation factors. All right. For this one, for the people who have been here since the first time, I want you guys to help me answer this. Deletion of all four normal, um, all four normal alpha globin genes will most likely to produce which of the following? Yeah, so you're having a alpha thalassemia, but in this case, you're deleting all four genes. Remember, exactly, D, hydrops fetalis, yeah? So I'll ask another question. At this time, which type of hemoglobin are you going to have? We mentioned it. That was the hemoglobin we were discussing. But exactly, that's nice. So we said that in case you're having all four genes deleted, you're going to have hemoglobin bats. And for hemoglobin bats, you're going to have hydrops fetalis, meaning that it's not going to be compatible with life. However, if you're having three of them being deleted, you're going to have hemoglobin H. Yeah, and hemoglobin H will result to a severe hemolytic anemia. Then we talked about if it's two, you're going to have an alpha thalassemia minor, and this will present as a microcytic microcomic anemia. Yeah. For Cooley's anemia happens with beta thalassemias. So for beta thalassemia, you only have two genes, and like this one, which is four. So if you're having one, you're going to have a beta thalassemia minor. And if you're having two, you're going to have the beta thalassemia major. Yeah. And for beta thalassemia major, another name for it is going to be the Cooley's anemia. So for beta thalassemia minor, it still presents with microcytic, microcomic, and for beta thalassemia major, it's going to present as a hemolytic anemia. Remember, we said that for thalassemias, it's going to be presenting in two ways, depending on the severity. Either it presents and we stated as one of the causes of microcytic, microcomic anemia, together with iron deficiencies and sideroblastic anemia, we say thalassemias can be. So this is the less severe one. But if it's a more severe one, you place it under a hemolytic anemia. Right. This is also a repeated question. We talked about how the mother is O positive and hence will not be having antigen A and antigen B. And we said that if you don't have the antigen, you're going to have the antibodies. So the antibodies here that are causing this hemolysis in the child is going to be anti-A and anti-B. But since she's also positive, the positive means she has the rhesus, and hence if you have the antigen D, she'll not be having an antibody D. So anti-D is not going to be an answer. The correct answer is going to be anti-A and anti-B, causing the problem in the child. Right, so antibodies made in the spleen that are directed against the cell surface antigens, the GP2B and 3A, or GP1B or an IX, are characteristically seen in individuals with. So who knows where these antigens are found? In which cell are these antigens going to be found? These cell surface antigens. All right. So the correct answer is going to be platelets, yeah? For platelets, you're going to be having these antigens. And these antigens are actually one of the ways in which you are able to have platelet aggregation and platelet function going about. So I told you we say that for platelet functions, we have the platelet activation, and then we have the platelet aggregation happening. Yeah. And it's a series of events that is happening. Last time we talked about the importance of von Willebrand factor being exposed for platelets to then be activated. After that one, it then expresses these antigens. Then these antigens will be able to bind with other platelets and activate other platelets. Yeah. So as they bind to other platelets, you're activating other platelets. So these antigens are really important in the functions of platelets. And where these antibodies against these antigens are going to be found is in the immune thrombocytopenic, the ITP, yeah. Immune thrombocytopenic purpura. It's going to be found in this one, yeah. And this is one of the antibodies we said in case of ITP. For your diagnosis, you're going to be able to find antibodies that are going to be targeted against this one. It's one of the diagnoses that are used in case of an ITP. Okay, someone says we repeat the previous question. Is it? I think it's the one for the mother. Okay, for those people who weren't here, we said that the child is going to be A positive, yeah? And we say that a general rule that we put was if you have an antigen, you're not going to have the antibody. But if you miss the antigen, you're going to have the antibody. So if, for example, you have a blood group A, so it means that you have antigen A, but you don't have antigen B. So if you don't have the antigen, you have the antibody. So blood group A has the antibodies against the thing that they don't have, which is B. So they'll have anti-B. Yeah. And blood group B, they have antigen B, but they lack antigen A. So they'll have antibodies against A. So they'll have anti-A. For our case here, our mother is going to have is blood type O positive. Yeah. So for an O positive, which antibodies does the mother have? The mother she lacks the antigen A and B, but she has antigen D, which is the rhesus. So if you have the rhesus, you have positive. Yeah. So she has the antigen D, but lacks antigen A and B. So if you have an antigen, you lack the antibody. If you lack the antigen, you have the antibody. So the mother cannot have anti-D because she has the rhesus antigen D. Yeah. So she can't have anti-D. What does she lack? She lacks antigen A and antigen B, meaning in her plasma, she has antibodies against those antigens. She has anti-A and anti-B. But why is that causing a problem? She's carrying a baby, yeah? And the baby, as is given birth, they notice jaundice, meaning there were antibodies that crossed the placenta to go and affect the child. Since the mother has anti-A and anti-B, and the child is an antigen A, yeah? So the antibodies that the mother has, which is A and B, so A is going to attack the antigens of the child because the child has antigens A, and hence you're going to have the hemolysis. Yeah. So what is causing hemolysis here is the mother's antibodies, anti-A and anti-B, which cross the placenta to go and attack the child's red blood cells, which are antigen A. Hopefully that's clear. Okay, so someone says, so antibody A and B can always cross the placenta. So here it's specified as an IgG. So you know that IgG is one of the characteristics of IgG is that it can cross the placenta, yeah? Okay. A recently diagnosed patient with SLE um, complains of fatigue. She's visibly pale on examination. Hemoglobin is going to be 8.9. So what laboratory test should be uh, uh, ordered to determine if anemia is due to an antibody? Yeah. So I think this one we have discussed several times, and you've said that if it's anything associated with an antibody, which SLE is producing autoantibodies against your cells, is going to be dealt with or be tested by a Coombs test. Yeah. So the Coombs test is going to be there. So we remember we talked about this one when we were talking about how we can differentiate different types causes of spherocytes. And we said one cause can be due to antibody, the other cause is going to be hereditary spherocytosis. So how do you differentiate if it is by checking out a Coombs test? Is there an antibody causing this problem? Yeah. So if you see an antibody with anemia, you want to do your Coombs test. Okay, can continue. Okay, a 5-year-old boy presents with recurrent hematolosis and intramuscular hematomas. Yeah, so laboratory tests reveal a normal bleeding time. Yeah, so we talked about, we said that if it's normal bleeding time, you have no problem with your primary hemostasis. Your platelet count is also normal and PT, but there's one problem: the APTT is prolonged. This boy's condition is most likely results from an abnormality involving. So you talked about, we said that APTT is going to be a measure of the intrinsic factor. Yeah. So you're now talking about your intrinsic coagulation factors. Yeah. And then you're being given a hint that this is actually a 5-year-old boy. Yeah. So if it's genetic, it's now associated with a boy. Yeah. And the association is going to be affecting the intrinsic factor. So if you follow that one, you're able to get to maybe this boy is suffering from a hemophilia A, hemophilia B. Yeah. And remember, we talked about hemophilia C yesterday. So the most way of inheritance of hemophilia is going to be an X chromosome, X chromosomal inheritance. Yeah. Though we can also have an acquired type. But this one we are being given too many hints. It's a young boy, yeah. So you're thinking about this is an inheritance, and then it's a boy, yeah. So you're thinking this is an X chromosome related, and then the person is having the hematolosis and also hematomas, and also this thing is affecting the APTT pathway, which is the intrinsic pathway. So you're thinking maybe factor 8 and factor 9 are going to be deficient. All right, so cryoprecipitate should be administered to treat which of the following patients? All right, so importantly is for you to identify what are the components of cryoprecipitate. Cryoprecipitate contains some certain factors. It contains factor 1, which is fibrinogen, contains factor 8, and contains the von Willebrand factor, as well as fibronectin. So within your choices, you just want to check out what's deficient. What am I trying to treat? Is it anything associated with factor 1, 8, 13, von Willebrand, or fibronectin? You just want to check out that one. So if you look at choice A, you're saying it's a factor 9 deficiency. You don't want to, it has nothing to deal with it. Choice B is still factor 9, has nothing to deal with it. Yeah. Choice C is our foreign toxicity. And yesterday we talked about vitamin K dependent factors, which we talked about to a factor 2, 7, 9, and 10. We said 2 plus 7 is 9, and then 10. None of these factors associated with a cryoprecipitate. Yeah. But look at choice D. Choice D is a trauma victim who has received 3 blood volumes of red blood cells and 3 units of platelets, but the patient has one problem. They have low fibrinogen. And we said that cryoprecipitate, one of the things that it has is going to be fibrinogen factor 1. So that's the correct answer. For thrombocytopenia, you just want to have your platelets. You're going to give the platelets, not a cryoprecipitate. All right. So a 3-year-old boy is tested for hemophilia because of a family history in the mother's side. The APTT was 75 seconds. The factor 8 was less than 1%, but factor 9 is 62%. Yeah. So you think now we're having a problem in factor 8. If the child develops bleeding, which transfusion product will be beneficial from the following choices? Would give me the answer. After we just mentioned it, cryoprecipitate. One of the factors that's going to be there is going to be factor 8, which is going to be useful in our case. Okay, you can continue. All right, which of the following is the best explanation why the ABO system is most important in blood group system in transfusion safety? So remember yesterday, I mentioned a very key important thing. I said the difference, what causes the delayed and the acute type of hemolytic transfusion reactions is going to be a difference in the blood, the grouping system. Yeah. And we said for ABO blood group system is really important because in case of a mistransfusion in an ABO blood group system, it's going to be rapid. It's going to be presenting itself as an acute type of hemolytic transfusion reaction. However, for the other types we said, like the Kell and the Diego and the Lewis and all the rest, and including the Ressas, they're going to present themselves as a delayed type of a transfusion reaction. And hence, a good reason, the best explanation, yeah, is going to be an ABO are often implicated in causes of rapid, severe intravascular hemolysis. Yeah, that's why it's really important to be able to know it. Yeah, because it's so rapid and sometimes you cannot be able to deal with it immediately. All right. So parasitic infections such as trichinosis, schistosomiasis, strongyloidiasis are characteristically cause an elevated number in peripheral blood off. So I think we talked about this one. We said that eosinophils, remember when I was giving an explanation that it's not a good phagocytic cell, we say that its main two functions are going to be in allergic reactions, which another question actually asked about it. And number 2 is this one, which are helminths. Yeah. So eosinophils are a key component in helminthic infections as well as in allergic reactions. That's when you're going to be presenting with an eosinophilia. You can continue. Net, you can continue. Right, a patient has the following white blood cells. It's 1 times 10 per 9. At the least likely cause disease. Remember yesterday Nate explained to us that the white blood cells and the values that are going to be 4 to 11, or sometimes within our setup is going to be 3.5 to 10. Yeah. So what we're having here is an leukopenia, yeah, a low white blood cells. So which is the least likely cause for this type of setup? Someone can tell me this one. Yeah. Okay. Yeah. Leukemia. Yeah. So remember, guys, when you want to define leukemia, yeah, remember yesterday when we were giving even a good explanation as to how you can be able to differentiate leukemia from a leukemoid reaction. Remember both of them in cases of leukemias, and that one, you're thinking about high levels of these blood cells within your body. They're infunctional, yes, but you're going to have high levels of these blood cells. Yeah. So the most correct answer here is going to be your chronic leukemia. If you just check out what's your ranges for your blood cells, your white blood cells, yeah, is going to be really high in cases of a leukemia. Remember, leukemia it's a part of a malignancies, and a characteristic of malignancies is going to be it's going to have too much proliferation than normal. Yeah. So you're going to have even more cells than normal. Yeah. The size of since you're not controlling the proliferation, and that's a definition of any malignant cell, you're having too many cells than normal. Yeah. So chronic leukemia, you're not going to have it being low, it's going to be high. All right, porphyrias result from the abnormal synthesis of. So you just go back to what porphyrias I used to make. What is a constituent of a porphyria? Yeah. So if you check out that in formation of a heme, yeah, for hemoglobin, let's start with hemoglobin. Hemoglobin has the heme component and the globin component. Yeah. The alpha and the one is going to be 2 alpha and 2 beta globin chains. Then the heme component is going to have an iron component and a porphyrin component. So in a porphyria where you're having abnormalities in formation or synthesis of these porphyrins and protoporphyrins, you're not going to be able to make this heme. Yeah. So the most correct answer here is going to be heme. I think 1 or 2 year near clean cap.
Yeah, but basically, albumin does never transport iron. Yeah, we know iron is transported by transferrin. 103, I'll do this one. Which one of the listed substances is secreted by malignant plasma cells in individuals with multiple myeloma and is the osteoclast activating factor that produces the characteristic lytic bone lesion? So I know of two. One, interleukin-1, and two, rank L. So rank L basically means receptor activator of nuclear factor, kappa B ligand. So basically what the question is asking is what will cause the lytic bone lesions, the ones we saw, the multiple, the punched out lesions, and responsible for stimulating osteoclast activity. So as I've said, there are two, interleukin-1 and rank L.
Right, for AIDS-defining malignancies, we say that we gave examples. There is a list you can check out. I think I can send it in the group. In the list, you're going to have clearly written some AIDS-defining malignancies and AIDS non-defining malignancies. On the other side, we talked about hematoma being one, hepatoma, and then in this case you're going to have an E. So I'll just send it in the group, the list that you're going to have. So here we're going to have it as a squamous cell carcinoma of the skin. All right. I think these questions you have already done. That's why he's skipping.
Is this hematology or immuno?
May mention it in both. You can just read. So defects in neutrophil NADPH oxidase system are produced which are the following. So yeah, it's part of immuno. You can just be able to refer to it, but you can just to mention it, an ADPH deficiency will present as a chronic granulomatous disease. Yeah, in part of white blood cells abnormalities, it was also mentioned as part of them, chronic granulomatous disease. Right, so administration of which of the following substances will theoretically, correct the abnormal bleeding laboratory test in an individual who is deficient in coagulation factor 5. So here what they're telling us is, instead of being able to give this factor 5, if we don't have the factor 5, how will we overcome the problem of factor 5? Yeah, how will we not in some sense not need factor 5 in that case? Yeah, so last time we were talking about the different types of what the intrinsic and extrinsic pathway. Then we said where they converge is that the activation of factor 10. Yeah, so that's where we start the common pathway. Factor 10 in presence of calcium, phospholipid, and also factor 5, we are able to activate factor 2, which is prothrombin. Yeah. So here we are trying to overcome, since we don't have factor 5. We don't care whatever is happening above. Yeah. So is it intrinsic? Is it extrinsic? We've already reached at the part where we are going to factor 10. So we don't have factor 5. How will we proceed? We need to be able to provide an active factor 2. Yeah. So to overcome the need of factor 5 being present for us to activate factor 2, why don't we just provide a factor 2, an active factor 2, to be able to complete the system? Yeah. So if you overcome it, factor 5, you provide thrombin, no prothrombin, because if you bring prothrombin, we are still having the problem of where are we going to activate the prothrombin into thrombin. So instead of bringing prothrombin, we bring its already active form, which is thrombin. Then thrombin will go ahead and activate fibrinogen and also factor 13, and then there'll be formation of the fibrin clot. Yeah. So to overcome this one, we'll be wanting to bring out thrombin, the active form of prothrombin. Right, immediate product from degradation of glycogen, from glycogen phosphorylase is going to be a glucose 1-phosphate. I'm not going to emphasize that one, more biochemistry and that whole process. Right, so a 7-year-old is diagnosed to having a deep vein thrombosis of the brachial vein. Yeah, the cause of this is not a deficiency of, yeah, so a deficiency of the following is not a cause of thrombosis. Yeah, so if you look at, we talked about, so what's thrombosis? Thrombosis is when you're not able to control your coagulation. Yeah, if your coagulation factors in some sense are not placed under control. And we say the control of coagulation is the anticoagulation system, yeah, the quaternary system. When we talked about antithrombin, is going to be the major part we talked about last time. And we also mentioned protein C and protein S. And we say that those ones are the vitamin K dependent anticoagulation factors. Yeah. And we know heparin. Heparin is going to be able to be there to be able to help antithrombin. Yeah. So all these ones are anticoagulation factors, except factor 5 Leiden. What's factor 5 Leiden? When you check out protein S and protein C, the complex that it will form as protein C complex, what it's going to have, it's going to be able to inactivate factor 5 and factor 8. Yeah, those two factors are going to be able to be activated by this one. Factor 5 Leiden is then a type of factor 5 which is not going to be able to be activated by this protein S and protein C. So rather than its deficiency, the presence of this factor 5 Leiden is going to be a cause of deep vein thrombosis. Hence, that's the answer. It's not a deficiency of factor 5 Leiden, rather the presence of it is going to be a problem. Right. A patient is receiving a transfusion of 1 therapeutic unit of platelets. Which of the following laboratory studies should be used to assess the effectiveness of therapy? Yeah, and we talked about that platelets. If you want to do a function of the platelets, which is part of the primary coagulation system, we said you want to do your bleeding time. Yeah, so tumerudia that a lot of time. Bleeding time is platelets and your blood vessels. So if you're giving platelets to be able to see that effectiveness of that therapy, you want to check out your bleeding time. Are my platelets functioning well? Yeah, are we doing your bleeding time? Is the platelet function being restored? Right. A 22-year-old male wants to know if he has a sickle cell trait. He has no previous history of the signs or symptoms of sickle cell anemia. What laboratory method or test can be used to detect the presence of hemoglobin S? Yeah. So you want to do osmotic fragility test. You know where you do it for in cases of a membrane nini. For example, you'd want to do it in a hereditary spherocytosis case. Coombs test tumerudia mara mingi. We've said it's done in cases of an autoimmune or antibody-associated hemolytic anemia. Schilling's test, you want to do it in a vitamin B12 deficiency. For sucrose hemolysis, test is also used to check out your membranes, for example, in hereditary spherocytosis. And the metabisulfate test is going to be the hemoglobin test. So metabisulfate is a reagent used in this sickling test. So if you want to do a sickling test, you use two reagents, either of the two. We have metabisulfate and dicyanate, yeah? So sodium dicyanate and metabisulfate. So those two are going to be used in sickling test, which can be used in detection or screening of sickle cell anemia.
Okay. So I think one of the last questions before we finish. Which of the following listed types of antibodies is the best example of a cold agglutinin that is associated with cold autoimmune hemolytic anemia? So, so the first thing is you have to ask yourself, what is a cold autoimmune hemolytic anemia, okay? So autoimmune hemolytic anemia, so it is autoimmune. So it's an autoimmune disorder where hemolysis will take place in, so it's cold, so temperatures less than the body temperatures, okay? So less than 37 degrees. And so these antibodies, we expect them to react with red blood cells, leading to hemolysis. So the best answer here is choice D, where an anti-P IgG antibody associated with paroxysmal cold hemoglobinuria. So this paroxysmal cold hemoglobinuria is a specific type of cold autoimmune hemolytic anemia. And the antibody that is present is anti-P. Yeah, so the answer is D. Then the last one before we finish. Physical examination that finds multiple palpable purpuric lesions on the legs of 7-year-old boy is most suggestive of. So here the differential that comes in mind when you hear multiple palpable purpuric lesions is the Henoch Scholen pupilla, or it was called that, or you can just say IgA vasculitis. It is a small vessel vasculitis. And yeah, so who can tell me the triad of IgA vasculitis? Who knows the triad of IgA vasculitis? So for the triad, how I usually remember it, I usually say, because it was called Henoch Scholen pupilla, HSP. So for the H is hinge pain. So when you say hinge pain, you mean arthralgia. Yes. Thank you, Sean. Arthralgia. S was the stomach pain. So stomach pain or abdominal pain. And then the P is the palpable pupilla, which is basically most likely in the legs and the buttocks. Yeah. So if you already know this is IgA vasculitis, it gets easier. So hemorrhage secondary to hypersensitive vasculitis. So that's the answer. So another thing that bleeding secondary to excess corticosteroids, that's wrong. Erythema secondary to active hyperemia, wrong. Telangiectasia secondary to congenital malformation, thrombosis secondary to viral, wrong. So eliminating B, C, and D are the obvious wrong answers. One would think D, but what is telangiectasia? And which conditions do we normally see it? There are three main conditions we normally see telangiectasia. So telangiectasia basically is they call it spider angiomata, where like you have like a spider formation, a web-like on the surface of the skin. So the most obvious one, which we all know, is cirrhosis. So when you have liver cirrhosis, and then these ones, the one in immunology, ataxia telangiectasia, which is a B cell and T cell deficiency. And then the last one is hereditary hemorrhagic telangiectasia. Those are the three that are normally seen. But the most common one we all know is liver cirrhosis. Yeah, so I think we can finish there. I'm seeing it's 10. So unless you have a question,